Thank you very much, Serge. Over the next 20 minutes or so, I want to talk to you about sequential therapy in osteoporosis, what we can find about sequential therapy in the guidelines, what's the evidence for sequential approaches to treatment, and how that impacts on our clinical practice. There are many reasons to consider sequential therapies. As I've said, long-term management is required, and of course we need to take into account the patient's preferences and choices about the treatment options that are available to them. When we start our patients on a particular treatment, however, there are problems with persistence and adherence. The patient might be intolerant of the medication. How can we manage changing therapies by monitoring the response to treatment is also important. In those who appear to have an inadequate or a failed response to treatment, then of course we must consider a change in treatment. There are several ways of defining that inadequate response shown on the slide here, such as a loss of BMD or perhaps a failure to gain sufficient BMD. Most commonly in clinical practice, we're looking at the occurrence of a fracture despite being on treatment, and that's really a trigger to consider a change in treatment. More recently, we've really started to think about sequential treatments as a means to optimize the treatment outcomes. And I'll explain a little bit more about that towards the end of this presentation. So first of all, what do the guidelines tell us about sequential therapy in osteoporosis? Well, until recently, there's been relatively little in the guidelines. There's been a lot of information about the treatment options that are available to us, but relatively little about the need to follow one treatment with another. At present, there is, however, a consensus on the need for anti-resorptive agents after anabolic therapy. And I've just shown you a couple of recent guideline examples on the slide here. That is recognized that when patients receive anabolic treatments for whatever duration that treatment is licensed for, then we know that the offset of effect is relatively rapid. And we need to maintain that effect by continuing with an anti-resorptive treatment after that anabolic therapy. As I've said, there are sort of four main categories that we might consider. At the bottom of this slide, we have that anti-resorptive following anabolic treatment, which is in the guidelines already. But there are other areas where sequential therapy can be considered. You might like to, for example, include bisphosphonate holidays as a sequential therapy where we have treatment periods followed by periods off treatment. As I've said, most of us in clinical practice come across sequential therapy when we need to actually change treatment in those with an inadequate response. And then there's a special case that I'll spend a few minutes on, just looking at the transition after denosumab treatment. And I would refer you to recent reviews on this topic from bodies such as the IOF and the European Calcified Tissue Society. But I'll say something from the latest trial that we have available on that. We've long recognized that adherence to oral medications in osteoporosis, as in any chronic disease, is much less optimal than we would hope. These are data from the SCOOP study, which was a community-based study of oral osteoporosis medications, predominantly oral bisphosphonates in the UK. And we're looking here at different time points that the patients commenced the bisphosphonate treatments. But you can see that at any time point when they commenced the treatment, within the first year or so, there's this fairly rapid decline of 40% in persistence or adherence with their medications. And then that tapers off, but still declines. And by the end of 2 years, 3 years, 60% or more have stopped taking their medication. So these patients need bone protection. We've made a decision to put them on treatment because they're deemed to be at sufficient risk of fracture, but they're not taking the treatment, and we need to think about what else we're going to give to them. Can we identify who's not going to take the medication? And there are many studies looking at this in the literature. Again, these are just data from the SCOOP study. You can see in the red rectangle here that age is a negative predictor of good adherence. So the older the patient, the less likely that they persist with their oral medications. Other things did influence the uptake of treatment and adherence with treatment. For example, a parental history of hip fracture was a significant predictor of good adherence. So that knowledge in the background of what happened to the parent modifies the patient's behavior in terms of taking the medication. Having access to a DEXA scan also had an impact. And that DEXA scan was part of the feeding back of their risk category, which was defined by FRAX as being high or low. And if you were in the high risk category, then you had an almost threefold increased likelihood of having good adherence within that study. So there are things that we can do and take note of that can try to improve adherence, but good long-term adherence with oral bisphosphonates is still a problem in clinical practice. Can we then identify those who fail to respond, and do they do worse? Well, actually, if you go back and look through the guidelines over many years, they have told us that we should use biochemical markers in assessing the response to treatment or monitoring the response to treatment. And that's our routine clinical practice in Sheffield, as I will show you in the next couple of slides. These are data from a comparative study that we conducted in Sheffield called the TRIO study. And here we're just looking at bone mineral density measured at 96 weeks from the start of treatment, compared to the CTX response at 12 weeks after the start of treatment. And you can see that we can judge the response if the serum CTX decreases by more than the least significant change. In this particular example, that was a 55% or greater decrease. In those women who got that response, there was a 6% increase in spine BMD, and there was a 3% or slightly more than 3% increase in total hip and femoral neck BMD. But in the women who didn't get that response, presumably through poor adherence or difficulty in adhering to the dosing instructions with the bisphosphonate, who didn't suppress their CTX, then we get much lower increases in BMD compared to the responders. So that group of women can then become a group that we can then focus in on and say, we can do better than this. We might need to consider changing treatment in these particular individuals. This is a complicated slide, but if you search the internet for the Sheffield protocol for monitoring osteoporosis, you can see that this is a protocol that we share with our primary care colleagues. So when we start our patients on oral bisphosphonates, we measure P1NP at the outset of treatment, and then we measure P1NP again at 6 months on treatment. And again, we have local thresholds, and the thresholds are shown on the slide here, that allow us to make decisions about whether the patient is responding well and can continue on that treatment, or needs further advice about compliance and how to take the medication, or needs to be considered for a change in treatment. If we've identified the patient who needs to change, then the question is, what do we change to? And of course, most of our patients are starting on an anti-resorptive medication, most commonly an oral bisphosphonate. So the options are really to change to another anti-resorptive, or to change to an anabolic treatment. Now, in the patients that I've just shown you that weren't responding well, then we can change to a bisphosphonate, either administered intravenously, so that we take the oral limitations of the oral administration out of the equation, or we could change to something such as subcutaneous denosumab. And this slide is just showing evidence from a study published by Paul Miller and colleagues, where they took over 600 postmenopausal women who were previously treated with oral bisphosphonates for at least 2 years and had baseline serum CTXs of up to 500 picograms per mil. They were randomized to be changed to denosumab, or zoledronic acid, and you can see that the increase in bone mineral density at the spine, the hip, the femoral neck, and the 1/3 radius is significantly greater in the patients who changed to denosumab compared to those who changed to zoledronic acid. Who benefits most from that switch? Well, these are data from another trial, not from the same trial, published by David Kendler and colleagues. And here we are looking at, if you look at the left-hand side of this slide, baseline CTX again. And here it's been broken down into quartiles at the time these patients were asked to change from alendronate to denosumab or to continue on alendronate therapy. And you can see that towards the right-hand side of that CTX graph, the patients who get the greatest increase in lumbar spine BMD with the transition to denosumab are those who had the highest bone turnover despite being on alendronate. So those patients who failed to suppress their bone turnover on the oral bisphosphonate, either through poor compliance, adherence, or other issues, are the ones that will get the increase in bone mineral density when we change to a more potent anti-resorptive therapy such as denosumab. So the sequence here is straightforward. If the patient isn't responding well to an oral anti-resorptive, we can change to a parenterally administered anti-resorptive. The rapid offset of the denosumab treatment needs to also be considered when we're thinking about changing from denosumab to anabolic treatments. And until recently, that was really a transition from denosumab to teriparatide. And on the left of this slide are data from the data study published by Ben Leader and colleagues. And I just draw your attention to the bottom left graph, the total hip BMD graph. And in red here, we see the impact on total hip BMD of changing treatment from denosumab to teriparatide. And again, you can see this fairly rapid decline in hip BMD within the first 6 to 12 months of the transition. We don't have any fracture data in this setting, but there just is a concern that the rapid bone loss ensuing after the cessation of denosumab is further increased by the addition of the teriparatide. As I mentioned, we don't have any fracture data in this setting. We don't have any fracture data in the setting of romosozumab transitioning to denosumab and then back to romosozumab, and that's shown on the right-hand half of this slide. But you can see the blue area on the graph here is where these patients received a 1-year course of denosumab and then transitioned back to romosozumab. And you can see that there's really no evidence of this rebound loss of BMD at the total hip or lumbar spine BMD. It's important to remember this is just a 1-year exposure. It's not as long as the 3 to 4 or 5-year exposure seen in the study from Denmark. So we need to keep this under consideration for future studies. But the change from anti-resorptive to anabolic treatments is certainly a sequence that is worth considering in patients who have perhaps not responded as well as we might like. And there are several studies now that show that this is a good option. So this is data from the Vero trial, which was a trial that looked at a comparison between oral risedronate and subcutaneous teriparatide over a 2-year time period. You can see that overall the Kaplan-Meier estimates for the pooled clinical fractures were much in favor of the anabolic treatment compared to the oral anti-resorptive, with a 52% reduction in pooled clinical fractures. And in the bottom half of that slide, this is another later analysis from the same study, looking at that response in patients who had been receiving previous treatment with bisphosphonates compared to non-bisphosphonate or treatment-naive patients. And you can see that in terms of vertebral fractures, then the reduction in fractures was very similar, whether you received an oral bisphosphonate or not. So changing to the anabolic treatment after the anti-resorptive seemed a highly effective thing to do in this subgroup of patients. Of course, we have more than teriparatide available to us now, so we've got romosozumab, and it's important to remember that not all anabolic therapies are the same. So again, this is a study from Bente Langdal and colleagues, and over 400 postmenopausal women who had more than 3 years of an oral bisphosphonate before entry to the study, with alendronate in the year before entry to the trial. And they were then randomized to receive romosozumab in the blue lines or teriparatide in the red lines. And you can see that at the lumbar spine, which is the bottom left, you can see the increase in lumbar spine BMD is significantly greater, transitioning to romosozumab, than the teriparatide. And at the hip and femoral neck sites, we see that very classical early pattern of a decrease in bone density due to the increase in bone remodeling seen with teriparatide and an opening of the remodeling space. And that's not a pattern that we see in the patients transitioning to romosozumab, which is more modeling-based bone formation. So one of the things I mentioned back at the beginning was optimizing patient management. So we've been talking up until now really about managing patients who perhaps aren't doing as well as we would like. They've had a treatment, they've maybe not responded as well to that, so what do we do next? We're now in a situation where we can get patients who are at very high risk of fracture and say, well, what's the optimal sequence of treatment in this particular individual? And if they're at very high risk, a lot of thought is now being given to using anabolic treatments as first line, followed by an anti-resorptive. And we have good evidence for not just the bone mineral density changes, which we've seen in the data study from Ben Leader and colleagues, but we also have some fracture data from the abaloparatide study followed by anti-resorptives, the active extend study, and also with romosozumab followed by anti-resorptives, either by denosumab in the FRAME study or by alendronate in the ARCH study. And these are data from the ARCH study. Actually, if you go back and look at the high-risk patients within the FRAME study, in that study, as you'll recall, they got placebo for the first year and then denosumab in both groups in the FRAME study. But you see fairly similar outcomes to what we see in this group of patients here from the ARCH study, who all had severe osteoporosis and were at increased risk of fracture. And on the left-hand side, we're looking at first clinical fracture, and on the right at first non-vertebral fracture. And you can see, you'll recall in this study, that the patients received oral alendronate or romosozumab for the first year, and then all the women received alendronate after that first year. And the important thing here, to my mind, is that if we look, for example, just at the first clinical fracture, is that the line of incidence of fracture in those women who first received romosozumab and then moved to alendronate continues to dissociate from those who got alendronate throughout. In my mind, this suggests that what I call the fracture trajectory has been altered by that initial treatment with the anabolic treatment up front. And that's an important observation. It means that in patients at particularly high risk of fracture, then the optimal combination is probably anabolic treatment first, followed by an anti-resorptive in the long term. And actually, that turns out not just to be an effective strategy for the patient, but probably as an effective strategy, certainly in overall fractures saved. And of course, depending on the economics and treatment costs, is probably likely to be a more cost-effective approach to treatment. So in this slide, for example, if you just focus in on the 75-year-old, in the fourth column, we're looking at the fractures saved in those women who, over a 10-year period, who had recently had a major osteoporotic fracture, were first treated for 18 months with an anabolic treatment, and then for the rest of the 10 years with an anti-resorptive treatment. And at the age of 75, in this setting, it's been estimated that we would save almost 52 hip fractures over the next 10 years. Whereas if we had the opposite approach and give them 18 months of, they gave them 8.5 years of the antiresorptive and the 18 months of anabolic at the end of the 10 years, we would only have saved 30 hip fractures. So it makes sense and is more effective to use the anabolic treatment up front. And that has led to a number of guidelines being updated about this consideration of the treatment that should be based on the underlying fracture risk. And this is a table from a recent publication from the IOF and ESCEO, looking at categories of risk at the time of deciding to start treatment, and in low-risk patients considering things such as menopausal hormone therapy, in high-risk patients looking at oral or intravenous bisphosphonates or denosumab, but in the very high-risk patients, then starting with an anabolic and then follow that by an anti-resorptive treatment. So to summarize, sequential therapy is a very pragmatic approach to optimize the long-term management of patients with osteoporosis. For many of the switches between antiresorptives, we don't have and are probably unlikely to ever have data on anti-fracture efficacy of those switches. But I think we have to assume that the benefits are there because of improvements in bone mineral density and biochemical markers of bone turnover. It's increasingly apparent that sequential treatment with first-line anabolic therapies followed by antiresorptives confer greater risk reductions than the antiresorptives alone, and this is becoming particularly important in patients at very high risk of fracture. Thank you very much.